Kia ora koutou. No ngā pui te iwi, no tamaki makaurau ahau, ko te tari hauora tūmata nui ahau, ko te whare wānanga o Otago ki te whanganui Atara ahau. Ko kairaruku mātua te mahi, ko Jason Gurney ahau. Well, good afternoon everybody. My name is Jason Gurney and I'm a Senior Research Fellow at the Department of Public Health at the University of Otago in Wellington. My area of research, as we'll get into, is cancer epidemiology, and we'll get into a little bit more about epidemiology in a little bit. But it's a real pleasure to be here to speak to you guys, especially coming out to sort of what I like to think of as more the flax route. So coming out and actually talking to people who are working at the clinical coalface with, trying to address the problems that we're going to talk about today. I've got bad news for you. This isn't going to be a happy presentation. A lot of it is bad news. There are some sustaining, consistent, strong, persisting, all the other adjectives, inequities in this country that we need to be aware of and we need to strive towards fixing. Whilst the news isn't good currently, I am a serial optimist, and I believe that the data that I'm going to show you today doesn't fill me with dread. It fills me with hope, and it fills me with a sense of opportunity. There is a lot of low-hanging fruit here and a lot of opportunity to improve cancer outcomes, in particular for Māori whānau. So the presentation today, again, it's not a happy one, but I think it's a story that needs to be told, and I'm very glad that you are here today. And I'd also like to acknowledge those who are watching either in the video after this presentation or around the South Island through the wonders of the internet. So the title of the talk is Cancer Inequities for Māori, Understanding the Current Evidence. Now this is just a little bit of a brief overview of the presentation today. We're set to go for about an hour, but I guarantee you we won't go for that long, so you'll be out here before then, I'm sure, or at least we will have time to maybe have some discussion and ask any questions that I will endeavour to try to answer. So the first thing that we're going to talk about is who are we? This isn't an existential question. We're not going to be sitting here for 10 minutes talking about the existential things about who we are. That's more just talking about our research group. I just wanted to share where I'm coming from and the work that we have been doing in that group. The second thing is to talk a little bit about equity, just so that we're on the same page about what equity is before we start getting into the nitty-gritty, which is talking about who gets cancer and who dies from cancer. And this is the inequities in cancer outcomes, the data that I want to share with you guys today. So after we've talked about who gets cancer and who dies from cancer, so cancer incidence, and largely we'll be talking about cancer mortality, we're going to talk about why, the reasons, the potential reasons why there are differences in survival and why these inequities exist between Māori and non-Māori. Spoiler alert, we don't have all of the answers, but we have some fairly substantial clues that I want to share with you. So we'll cover patient-level factors, for example, patient comorbidity, but we'll also cover system-level factors using some of the work that our department has and our research group has been involved in terms of colon cancer in particular. So let's start with the existential question, who are we? So this is my boss, Diana Safati, who some of you may know, Professor Diana Safati. She's actually the head of our department. This is our department in Wellington. We are literally tacked on to the side of the hospital in some very dodgy buildings in a highly earthquake-prone zone, which doesn't make us feel terribly comfortable at all times. We're up on sort of this level around about here. And within that department, we have a series of research groups. And one of those research groups is our research group, which is directed by Di Safati, and I am the deputy director of that group. And that group is called the Cancer and Chronic Conditions Research Group, or C3, because there's 3 C's in it. It's basically as much as we thought about that one. So the Cancer and Chronic Conditions Research Group is kind of eponymous. We do a lot of work at the intersection between cancer and comorbidity. The C3 study, which is I started back at the end of 2010 working within 4DI, And that study that I was working on was the C3 project, which I'm going to show you some data from the C3 project today, where we looked at a host of 9 different cancers across the spectrum, and looked at the impact of patient comorbidity on inequities in cancer treatment and outcomes for Māori patients compared to non-Māori patients. So there's some quite interesting findings from that study. So that's just a little bit by way of background to say that the work that we do has a very strong equity focus, a very strong focus on trying to explain some of the differences that have been observed, a lot of which have been observed in our building by people like my boss Di, as well as others like Professor Tony Blakely. So, you know, our research group does a lot of kind of work in this area, so we are very passionate about trying to make an impact in it. Now, the science that we practice is called epidemiology. Most of you, I'm sure, are aware of epidemiology. If you were to look up in a textbook what epidemiology is, it will say that it's the study of the distribution and determinants of disease at a population level. Distribution, so who gets disease. Determinants, why do they get the disease at a population level. But I think there's actually a much better way of phrasing that, which is epidemiology is people's stories with the tears wiped away. We have quite a large responsibility in epidemiology. We sit with these massive data sets of often 10,000 plus, usually more than that, usually hundreds of thousands of people. All of the data, in one row of data, all of the most pertinent information in terms of the darkest moment of that person's life. So it might be information about how sick they were at a given point in time, and the procedures that they received for their cancer at the given stage of disease, their outcomes, their mortality outcomes. And we don't take that lightly. People are always at the centre of our research. People's stories are always at the centre of our research, and we do a lot of work that combines quantitative, I'm a big quantitative data nerd, but we also combine a lot of qualitative work in what we do so that we have those people's stories feeding through. Because we believe that it's incredibly important to have one informing the other, whether the qualitative informs the quantitative or the other way around. It works both ways. So we like to think of epidemiology as people's stories with the tears wiped away. So just before we kind of kick on to getting into the nitty-gritty and showing you some data, I just wanted to have a brief word about what equity is. So two things about this graph. One is, as I've alluded to, I'm a data nerd, so I'm going to be throwing a heck of a lot of data at you today, but don't panic, I will walk you through everything that I show. The second thing is I'll probably talk about testicular cancer about 93 times, and the reason for that is my kind of area of expertise. Testicular cancer epidemiology is where I do quite a lot of my nitty-gritty work. So I like to work it into absolutely every presentation that I do. This is testicular cancer rates from 1950 through to 2010. And on this vertical axis here, we have the age standardised rate of disease for every 100,000 males in New Zealand. Now, this is on the horizontal axis here, we have basically just time. So this is ranging from 1950 through to 2010. And what we see is that back in 1950, rates of testicular cancer were sitting around about 2 cases for every 100,000. Whereas in 2010, it's raised up to about 8 cases per 100,000. In fact, in more recent work that we've done, it's actually going higher than that. It's kind of increasing unabated, which is one of the reasons why we're doing quite a lot of work in this area. I'm just about to start pilot data collection for a large case control study, which is looking at what is causing testicular cancer in New Zealand, because we've observed some, speaking of inequities, we've observed some very strange, puzzling, unique inequities in terms of the incidence of testicular cancer in New Zealand, where Māori males are, for some reason, 80% more likely to develop testicular cancer than European males, and it's the only known example in the world where a non-European population has the highest rates of testicular cancer. Not only that, Māori males are substantially upwards of 3 times more likely to develop testicular cancer than Pacific males. You can count the number of cases of testicular cancer that happen among Pacific males on one hand per year. It's very, very, very rare among Pacific males, not so for Māori males. So our belief is that if we can figure out what's causing high rates of testicular cancer among Māori males, we might actually be able to say something quite meaningful about what causes testicular cancer in general, not only explain an inequity, but also figure out what's actually causing testicular cancer, which is a big deal because there's only a couple of strong known risk factors for testicular cancer. That's my way of saying I will talk about testicular cancer until I'm red in the face. Essentially, what this data is telling us is that rates of testicular cancer are increasing over time. Now, I didn't just bring up the slide to talk about testicular cancer, although I do that anyway. I brought it up to basically make a point. And my point is this. Obviously, this is rates of testicular cancer incidence among males. If I were to plot rates of testicular cancer incidence among females, it would look something like this. So, I don't believe that there's actually ever been a recorded occurrence of testicular cancer among females. Now, clearly, this is an inequality. It is not an inequity. Inequality just means that things are different or unequal between groups. But like testicular cancer rates between sexes, this difference might be completely inevitable. The word inequity, on the other hand, refers to fairness. It's fair that men suffer greater rates of testicular cancer than women. However, it is completely unfair that Māori men are more than twice as likely to die of testicular cancer than non-Māori men, which we are. And that's adjusting, before anyone asks, it's adjusting for age and sex and stage of disease. So, fair, men suffer greater rates of testicular cancer than women. Not fair, Māori men are more than twice as likely to die of testicular cancer than non-Māori men. And this is a lovely quote from Ho Order 4. If you get a chance to read Ho Order 4, it's an excellent report. It needs updating. I think that's happening imminently, perhaps. Written by, this section of the book was written by Papa Arangi Reid from the University of Auckland and Bridget Robson, who is the director of the Edipo Māori Health Research Centre at our department in Wellington. And they said this lovely quote, "Equity, like fairness, is an ethical concept. It does not necessarily mean that resources are equally shared. Rather, it acknowledges that sometimes different resourcing is needed in order that different groups enjoy equitable health outcomes." And today we're going to talk about differences in cancer outcomes between Māori and non-Māori that are unfair, or in other words, inequitable. So, with that kind of covered, let's start getting into some nitty-gritty about data, about the data around this.
So can I just ask a question?
Sure.
Your graph that said that how many men in 100,000, if you took just the Māori population, would that be even higher for 100,000 men? Is that
Correct.
just 100,000 in New Zealand?
This is total rate. Yep, that's correct.
So if you took out non-Māori, would that give you a higher figure?
Yes, so if this was male compared to Māori compared to non-Māori, the graph would be much higher. Yep. So as I was mentioning, 80% higher rates among Māori compared to Europeans. So, inequities in cancer outcomes. We're going to talk about who gets cancer, so that's cancer incidence. And then we're going to talk about who dies from cancer. That's cancer. We're going to primarily talk about cancer mortality in this case. So let's start with cancer incidence. Now, I'm going to throw a whole lot of data at you. The data that I'm going to show you now is from the Nzd Cms study, which is the New Zealand Cancer Mortality Study, and that was led by Professor Tony Blakely from our department. And the reason I bring that up is that they've developed a fantastic tool called the Nzd Cms Data Explorer. So all of this data I got online. Essentially, I did a lot of this in a hotel room once, like about 6 months ago. It's very, very easy to design your own graphs that you want to see, look at trends over time. It's a fantastic resource if you ever want to look at these sorts of things over time. It does a whole lot of different things. It's not just ethnicity. You can look at things by education, by income, etc. Anyway, back to the story at hand. This is the same vertical axis that we had on that last graph that I showed you. So this is age standardised rate of disease for every 100,000 New Zealanders. It's important to remember this is for the total population. And across this horizontal axis here we have time. And each of these time dots here refer to census periods, because the Nzd Cms study basically used census periods as cohorts. So each of these dots refer to different cohorts. And again, this is rate of disease per 100,000. I've only plotted Māori against European just to illustrate the points for today, but you can easily go and add in Asian populations, Pacific populations, etc. So what we see for stomach cancer is essentially night and day. We see that rates of stomach cancer are much higher among the Māori population and increasingly diminishing for the European population, but more or less, you would say almost plateauing essentially certainly for Māori females. Now, a lot of the work that is going on, particularly in our research group around trying to address this, has to do with Helicobacter pylori. So one of the primary drivers of this inequity is most likely to be Helicobacter pylori, and we're doing quite a bit of work around trying to measure prevalence and also look at the potential for screening for Helicobacter pylori. So that's stomach cancer incidence. Lung cancer. Now, I don't really even need to flick to the next slide to illustrate to you what this one's going to look like. This is lung cancer incidence between Māori and European New Zealanders. We see ever increasing or ever decreasing rates among European males, but essentially in recent years, troublingly, we have plateauing rates, if not increasing rates, among Māori males. An absolute night and day in terms of the incidence of lung cancer between Māori and European, and of course this is driven by tobacco. Colorectal cancer is quite an interesting one. Colorectal cancer has received quite a lot of attention in recent times because of the screening program that is now being rolled out. Overall, I guess the take-home message in terms of colorectal cancer is that Māori actually have lower rates of colorectal cancer than the European population. This is less obvious for males than it is for females. Certainly you can see that it's quite different for females than it is for males. But certainly overall the take-home message is that Māori do have lower rates, although this disparity is closing, this gap is closing. Breast cancer. Breast cancer is really interesting, particularly this incidence slide, but also when we come back and talk about the mortality a little bit later on. This is rates of breast cancer incidence between Māori and European New Zealanders. And what we see is that rates of breast cancer are slowly coming down, plateauing if not coming down for European females, but increasing unabated for Māori females. And remember what this graph looks like when we come back to talking about mortality in a little bit. Prostate cancer. Prostate cancer, much like breast cancer, is quite an interesting one as well. We have rates of prostate cancer between Māori and European populations relatively similar. European do have higher rates of prostate cancer than Māori, but certainly not night and day. The two groups kind of loosely follow each other or mirror each other over time. This dramatic increase over time, of course, is largely driven by the advent of PSA testing and the increasing commonality of PSA testing. And what we have is a marginal difference between the two. But what I do want you to do is just take a mental snapshot of what this graph looks like, and then later on what the mortality graph looks like, because it paints a different picture. Melanoma. Melanoma is an interesting one. I included this because I wanted to make a point later on about mortality again, just because the way that you look at things can sometimes depend on how you've cut and sliced the data. And so I just wanted to illustrate that point to you all today. So melanoma, I mean, if you want to talk about inequity in melanoma, this is in the opposite direction. Here we have European, of course, the European population, rates of melanoma increasing relatively unabated for both males and females, but more or less plateaued and even for Māori males. So again, the primary purpose of showing you this is just to make a point later on when we talk about mortality. So when we combine all of the cancers together, so this is all cancers combined, what we see is that Māori males have slightly higher rates of cancer. So this is the whole population again. So Māori males are marginally more likely to develop cancer than European males, but Māori females are much more likely to develop cancer than European females. So in general, Māori more likely, marginally to moderately more likely to develop cancer than European population. So that's who gets cancer. Now I took those cancers, or else we'd be here all day. We could go through and do a whole lot of other cancers, but I wanted to choose those ones to just talk about today. But there are similar stories across other cancers. So now what about who dies from cancer? So this is primarily, we're going to be talking about mortality for this one. Let's go back to talking about stomach cancer. So this is now exactly the same vertical axis where we have the standardized rate per 100,000, but in this case, think of it in terms of how many people in the general population are likely to die of stomach cancer. And what we see is that Māori males, when we calculate these things called age standardized rate ratios, what we see is that Māori males are around 3.5 times more likely to die of stomach cancer compared to European males. Māori females are around about 6 times more likely to die of stomach cancer compared to European females. So a substantial inequity existing for stomach cancer. And we do see decreases over time, but that disparity is persistent. Lung cancer, I mean, again, do I really need to even flick to the next slide? What we see again is that Māori males are around about 3.5 times more likely to die of lung cancer compared to European males. Māori females even more likely. Māori females 4 times more likely to die of lung cancer compared to European females. So a substantial, persistent, consistent inequity in terms of lung cancer mortality. Colorectal cancer is, again, it's the main purpose of including this colorectal cancer, the incidence data and this mortality data was mainly because it's been sort of a hot topic of late. But in terms of mortality, we have, for lack of, I recognise this as poor phrasing, we have kind of a mixed bag where you have Māori males and around slightly more likely to die of colorectal cancer than European males, but commensurately Māori females slightly less likely to die of colorectal cancer than European females. So this is a difficult one to untangle, and there is certainly no clear night and day relationship happening for colorectal cancer. Now again, it's important to remember that this is with respect to the total population. So this isn't just among patients with colorectal cancer, this is for all of us, our likelihood of dying of colorectal cancer. Breast cancer, so if you recall back from the incidence graph that I was showing you with that Māori rates for Māori sort of increasing unabated and rates for the European population more or less plateau, we see a very similar thing in terms of mortality, but even worse, we see decreasing rates of death from, or death from breast cancer in the total population among the European population, but that increasing rates of death from breast cancer among the Māori population, to the extent where now in that most recent census period, Māori females are twice as likely to die of breast cancer compared to European females. Prostate cancer, similarly, bring back that snapshot of the incidence curve where we had European actually ever so slightly higher rates of prostate cancer, but a very marginal difference, if any, between the two. The image that we see for mortality is completely different. In this most recent census period, we see that Māori males are twice as likely, like breast cancer, twice as likely to die of prostate cancer compared to the European population. Now, melanoma, this is my sort of place where I make a point about how you cut and slice the data. So if we were to look at the mortality data for the total population, as you might expect based on that incidence data that we showed before, the rates of mortality from melanoma are actually very low among Māori, which makes sense, right? If Māori are less likely to have melanoma, they're also less likely to die from melanoma when you consider things in the general population. Māori have less burden of melanoma, therefore Māori are less likely to die of melanoma. And so we do see that Māori are around 70% to 75% less likely to die of melanoma. However, all of these rates are relative to the total New Zealand population, as I've been sort of describing so far in the presentation. What if, instead of looking at the total population, you just took patients who had melanoma? So let's say on the 1st of April, 200 patients were diagnosed with melanoma. 100 patients who were Māori, 100 patients who were non-Māori. And then you then compared those two groups in terms of their mortality outcomes. What picture do you get? The answer is you get a completely different picture. even if you adjust for age, sex and stage, if you compare those 100 Māori and those 100 non-Māori in terms of their mortality from their cancer, or actually this is all cause, so this is from any cause, Māori are 50% more likely to die. Which is a completely different story, right? If we look at this, we like to think, oh well, Māori is 70% less likely to die of melanoma, but actually that's for the total population. This is for patients that actually have melanoma. So it's important to remember where that data is coming from and remember which groups that you are actually comparing. If we return back to looking at the total population data, this is now combined data for all cancers. And what we see is that when we combine all of those cancers together, we see that Māori are roughly twice as likely to die of any cancer compared to the European population. So this is all cancers combined, just to kind of reassure you I hadn't just picked and chosen cancers that illustrate the story strongly for me. This is across all cancers combined. This figure here kind of takes things home quite nicely, I think, in terms of illustrating the dramatic problem that we have here. This is data from the Cancer Trends study, this publication was led by Matt Soberg from our department. And this is the percentage difference in cancer mortality between Māori and non-Māori between 91 and 2004, so those were those census periods. And this is cancers, so this is all major cancers here lined up on this vertical axis. This red box here is just a pooled estimate across them. And the extent to which those black bars push over to the right is the extent to which Māori have poorer survival from that cancer. The extent to which the bars pull over to the left is the extent to which non-Māori have poorer survival from that cancer. And the take-home message is here, there aren't many bars pulling to the left. You have a lot of bars pulling over to the right with Māori having poorer survival from the cancer. And when we kind of put all this together, and this is again data from the unequal impact study, what we see is that Māori have around about 18% higher incidence from cancer. So Māori are around 18% more likely to get cancer, but more than twice as likely to die from it. 18% more likely to get it, but once they've got it, 18% more likely to die from it. So that's the kind of nitty-gritty. That's basically the objective evidence that we're sitting on with respect to who gets cancer and who dies from cancer in terms of inequities between Māori and non-Māori in New Zealand. But why? Why do these differences exist? Now again, as I said at the outset, we don't have all the answers. We're working on it. There's a lot of us working on it in the country. It's not just us that are working on this. But we have done quite a bit of work in this context, and we think we have some rather substantial clues that we are going to continue to work on. The first lot of clues that I want to work on and talk about today is patient level factors, and then the second, so like for example comorbidity, and the second thing we'll talk about is system level factors. Now we could talk about, for the rest of the day about the possible reasons for these inequities, but I'm only going to cover some of the more commonly discussed reasons because I think some of the evidence might surprise you. So let's talk a little bit about patient level factors. So what about comorbidity? What about this idea that Māori are less likely to survive their cancer because Māori are sicker? Māori have a higher burden of comorbidity. Well, as mentioned at the outset of this presentation, we did a lot of work in terms of the sort of the confluence between comorbidity and cancer. We did quite a bit of that in our research group. And as part of the C3 study, we looked at 9 separate cancers, which is these 9 cancers here. And as mentioned, we looked at the impact of patient comorbidity on things like inequities in treatment access and also inequities in terms of cancer survival. This data here that I'm showing is just the crude prevalence. This is just how common hypertension, and I'm going to show you a few other conditions, how common these comorbid conditions are among the patients with these cancers. So this is patients with stomach cancer, bladder cancer, liver cancer, etc. This is across the whole country. This isn't just a few hundred. This is several thousand in each group. And so what we have here is the extent to which these blue lines roll out here is how prevalent, for example, primary hypertension is. The blue bars are non-Māori, the red bars are Māori. So we see that more or less entirely across the board, Māori are more likely to have hypertension. Diabetes, the difference is even more dramatic. This is the prevalence, how common diabetes is among non-Māori patients with these cancers. This is Māori. So a dramatic difference in terms of the underlying prevalence of diabetes among these patients. This is a very interesting one. This is chronic viral hepatitis, obviously one of the primary risk factors in this context for liver cancer. This is the prevalence of chronic viral hepatitis among non-Māori. This is Māori. So we have a substantially greater burden of chronic viral hepatitis, not only among Māori patients with liver cancer, which is why chronic viral hepatitis is known to be one of the primary risk factors of interest in terms of the development of liver cancer for Māori, but also we have a higher prevalence of hepatitis across a number of other cancers. And it's important to sort of bring the point home by saying, yes, Māori are more likely to have some substantially important comorbid conditions. But not only that, the kicker to that is a high comorbidity burden does increase the likelihood of mortality. So this is a scary looking group of graphs that I will walk you through, I promise. This is cancer patient mortality, and this is increasing comorbidity. So what this thing on the vertical axis is, 0, 1, 2, 3, that's something called the C3 score. Some people might have heard of the Charlson score. The C3 score is the cancer-specific comorbidity score that we developed that works much better in cancer populations than Charlson does. So we say. So this is increasing comorbidity burden on the vertical axis here, and the horizontal axis is excess mortality. And this is adjusted for age, sex, and stage as well. And what we see, the take-home message here is that as that level of comorbidity increases for each of these groups of cancers here, so too does the likelihood of mortality. So the sicker you are, the more likely you are to die. So having comorbidity is important. Is the take-home message. No, this is generally just making.
But if you drew the ethnicity,
yep.
If you went to your old side and put ethnicity in red,
yep.
would the blue bar be bigger, but the pattern the same, or are they more or less the same?
Similar. So we're actually looking at something a little bit different here. We're looking at the independent impact of comorbidity on mortality among cancer patients. And when we stratify that out and separate out between Māori and non-Māori, that impact is greater for Māori than it is for non-Māori. Yeah, yeah. Generally speaking, it's hard to generalise about those things, but it differs depending on cancer. Yeah.
And you're talking here about death from cancer.
This is all cause. So this is all cause. But when when we separate out and do cancer-specific mortality, you see the same picture. It's just that cancer-specific, all-cause mortality allows you to include everyone in your cohort into the study, as opposed to cancer-specific, which you have to drop some patients off. So that's this is all-cause, but you get the same picture if you look at cancer-specific mortality. Now, what about deprivation? What about the idea that Māori have poor survival from cancer, because Māori are also more likely to live in deprivation or in areas of deprivation, and all of the things that come along with living in deprivation, which we could talk at length about. This is a really telling figure that I really like very much. This again is from the Unequal Impact report that Bridget and others put together. And this here is the age standardised rate again per 100,000, and this along this vertical axis. Along this horizontal axis is deprivation decile. So this is starting at this end, this is 1 through 10, and we have 1 is the least deprived decile, 10 is the most deprived decile. So this is, the people that developed this would hate me saying this, rich, poor. That's not really what it means, but the shortcut is rich, poor. And what we have here is, in terms of incidence, if we look first at incidence, we see that Māori are more likely to get cancer across all of these deprivation deciles. However, the differences between Māori and non-Māori are not substantial for a number of these, certainly these least deprived deciles. However, when we look at mortality, the difference is much more substantial. And the take-home message from this graph is at no point do these two meet? Do these two cross over or are similar? In other words, no matter how rich a Māori population is, they are still substantially more likely to die than the European population. So you cannot possibly explain all of the differences that we're observing in terms of mortality differences for Māori compared to non-Māori by saying it's because Māori are poorer. Because we see across all deciles, Māori are still more likely to die. Yes, at the most deprived end of the scale, the difference is greatest, but we still see a similar pattern in the least deprived scale. What about stage of disease? We've done quite a bit of work around here, around the context of stage of disease. There is a lot of talk, some would call it dogma, that Māori are more likely to die of their cancer because Māori present late. That it's Māori's fault because they're not turning up for their appointments. They're not getting into the system early enough. If they just got to the system early enough, we'd be able to treat them, it would be fine. There is a lot of problems with that dogma, and some of the data that I'm going to show you challenges some of that dogma. This is again data from the C3 study. This is across those 9 different cancers, and this is the proportion who are diagnosed with advanced disease. So this is a disease that has metastasized. And this is just the proportion with advanced disease, and these blue bars are for non-Māori, the red bars are for Māori. And what we see is, yes, it is true that for some cancers, Māori are more likely to present with advanced disease, notable ones being colon cancer, rectal cancer, and also breast cancer, although we do note that this is a small proportion of patients presenting with advanced disease. But for some cancers, from some other cancers, it's actually in the opposite direction. So yes, it is true that for some cancers, Māori are more likely to present with advanced disease, but it is certainly not a rule of thumb as far as we have observed. So my take-home message from this perspective is it is a fallacy to fall back on the argument that Māori are more likely to die of cancer because they are presenting with more advanced disease. Because, as we'll get to in a second, with some other data from the colon cancer study, this isn't consistent, and it's certainly not what we're seeing for a number of different cancers. So, why are the differences in survival? So we've talked about those patient-level factors. We've talked about the potential importance of comorbidity. We've talked a little bit about deprivation, and also we've talked just about stage of disease. Now we're going to talk a little bit about system-level factors. And for system-level factors, I want to use the example of colon cancer because that's the colon cancer study that Sarah Hill and Di Safati, my boss, did a few years ago. This is actually before I arrived. Provided some really interesting evidence in this regard. So this study looked at 300 Māori and 300 non-Māori. It was a clinical notes review around the country of colon cancer patients. It looked at 300 Māori, 300 non-Māori, and compared survival from colon cancer, and then the reasons for disparities in survival between those groups. And this here is excess mortality. And this is data from the Sarah Hill's study. And this is the Māori, non-Māori disparity in colon cancer survival. So just to interpret this, what this unadjusted graph here means is that Māori were about 33%, I believe, more likely to die of colon cancer within that cohort. So remember, this isn't the population level, this is just patients who have colon cancer. We're 33% more likely to die of colon cancer when you don't adjust for anything in your models. If you adjust for differences in age and sex, and I believe that was the only other demographic variables, it drops to around about 30%, but it's negligible. If you then add in disease factors, so that's stage of disease, as well as other disease factors, it bounces back up to 33%. If you then adjust for factors that are largely comorbidity-related factors, so patient-level factors relating to comorbidity status, that explains around about a third of the disparity between colon cancer, in terms of colon cancer mortality between Māori and non-Māori. If you then additionally adjust for factors related to treatment and health service access, as we'll get to in a second, you can explain a further third of that disparity, where the disparity then drops down to less than 10%. Hill and Di and others observed that comorbidity and treatment health service factors each explained around about a third of that survival difference. And they also observed some really interesting stuff with respect to health service access, primarily for patients with stage 3 disease. And what they did is this figure here, I'll walk you through it again. This is looking at the proportion of patients within their cohort that received a certain type of service here. And what we see is that, but this is on the left-hand bars here are Māori and the right-hand bars are non-Māori. And the take-home message from this is that at each step along here, Māori aren't doing substantially worse than non-Māori. There isn't night and day in terms of what's happening here. But we see that Māori were just slightly less likely to be referred to an oncologist. And if referred to an oncologist, Māori were slightly less likely to be reviewed by an oncologist. And if they were reviewed by an oncologist, they were slightly less likely to be offered adjuvant chemotherapy. And then if offered adjuvant chemotherapy, slightly less likely to receive it. And then if they were to receive it, less likely to start within 8 weeks. Now, at each one of those steps along the pathway, the differences between Māori and non-Māori were not substantial. But when you add them up and you put them all together, you end up with a pretty substantial difference where you have around about just over 20% of stage 3 colon cancer patients who are Māori starting their chemotherapy within 8 weeks compared to more than 40% of non-Māori. So this data gives us some appreciation of the fact that, yes, we may not be seeing substantial differences at each step, but when you add them up, it counts. It adds up to something important. And it's not just our group in the context of colon cancer who've found this. Stevens and colleagues observed similar results in the context of lung cancer. So this is a lung cancer study that Stevens et al. Did. And they found that Māori was 70% less likely to receive curative treatment for their lung cancer and 4 times more likely to receive palliative treatment for non-metastatic tumours. And that was adjusted for the kitchen sink. That was adjusted for age, sex, stage, comorbidity, deprivation, basically everything. So it's not just colon cancer that's been observed in. So, a very brief summary. Māori are 18% more likely to be diagnosed with cancer, but nearly twice as likely to die from it. Cancer-specific survival, so this is that curve that I showed you earlier with all those cancers along the vertical axis and those bars pulling out to the right. Cancer-specific survival is lower for Māori than non-Māori for most cancers. And there is good evidence that at least some of this difference in survival is due to health service factors, but obviously we are doing further work in this context looking at different cancers. So, where do we go from here? I'm very passionate about doing work in this area. I believe that it's, as I said at the outset, that there are a lot of opportunities here to make an impact. And our group are doing a lot of work in this area. So I'll just touch on a couple of things that we are doing. The first thing, with respect to those appalling stomach cancer rates, we are doing quite a bit of work in the context of stomach cancer, particularly around prevention and care and looking at H. pylori prevalence and the potential for screening. I am working on testicular cancer etiology, as I've been over with you already in quite enough detail for you, I'm sure, for one day. My colleague Ruth Cunningham is doing quite a lot of work at the confluence between cancer and mental health. So that's a very interesting burgeoning area of interest and work that she's doing. She's taken a little bit of a backward step on that, I think, at the moment, because she's quite involved in the mental health inquiry. We are doing quite a lot of work in terms of cancer control in the Pacific, and in fact, Di, my boss, is just over at the International Agency for Research in Cancer, which is the WHO's cancer body at the moment, and they've just signed an agreement with the University of Otago to start helping us to develop things around infrastructure in terms of doing things like measuring the burden of cancer in the Pacific and potentially doing things like developing registries, etc., which is related to the work that we do in the context of cancer in Indigenous populations. The story that I've shared today is not restricted to New Zealand. Our colleagues, whānau from Australia, at our Indigenous Cancer population, Indigenous Cancer symposium that we had in February, they came over and showed us their data, and it's a very, very similar story for a number of cancers. Obviously a different context, but this cancer disparities in cancer outcomes is a big problem worldwide, not just in New Zealand. And also I'm leading some new work looking at setting cancer priorities for Māori. Strongly believe that in order to make sustainable change in this area, we need to set some priorities and strive towards them to achieve them. And so that's what's going to consume me for the next few years, is working on setting those priorities and coming up with some meaningful ways to address them. I just want to acknowledge my boss and also Tony and the Nzd Cms team, my department, and Te Ahuru Mowai, which is the National Māori Cancer Leadership Group, of which Melissa is also a member, and I'm a member too. Also the Health Research Council, who fund a lot of our research, and the Ministry of Health, who have been great as well. So that's me. Thank you very much for listening.